Now we can move on, I think.
Thank you so much. We want to introduce our next guest, our next speaker. Following a sarcoma diagnosis, many patients and carers often express real concerns about hereditary predispositions. Is there a risk I can transmit my disease to my child? My mother got cancer. Do you think I have inherited my tumor from her? It's apart from very specific, often difficult to answer this question. Even though most sarcomas often occur sporadically, some rare inherited conditions can be considered as risk factors for soft tissue sarcomas. So it is my pleasure to welcome Dr. Margarita Raygada, oncology genetic counselor and geneticist at Georgetown University, to discuss this. Thank you.
Thank you for the introduction. Just one small correction. I don't work at Georgetown University. I work at NCI.
Oh, I'm so sorry.
I'm actually the geneticist, genetic counselor working with the pediatric oncology branch at NCI with Brigida and John and Mary Frances. So I was at Georgetown before you were all born. So that's old information. Anyways, I have no conflicts of interest. You can tell I work for the government because that's my first slide. The one to the right, the one to the left, it's not moving. Oh, to the left, okay. So what I want to do today is give you a brief summary of the approach to the patients that come to the sarcoma clinics in NIH and for the genetic assessment, genetic counseling, and genetic testing. And then at the end, talk a little bit about the challenges that we face. And, oh, it's going backwards. Because we have a broad audience here today, I want to begin with a general knowledge on the type of testing, general discussions of the type of testings that we do in all cancer patients. And this only applies to cancer patients with solid tumors. So there's two types of testing: germline testing, and this is usually done on blood or saliva. And this is where we're testing the DNA that the person was born with that will pass on. And we can do different types of testing nowadays. We can do single gene testing, and that's when we either suspect a specific syndrome or there is a familial mutation that's running in the family. We can also do a panel of multiple cancer genes based on whatever the family history is saying or the medical history, or we can do more comprehensive testing, which would be whole exome sequencing or whole genome sequencing. And the purpose of this testing is to identify whether or not the person was born with a predisposition to cancer or whether the person has a hereditary cancer condition. And the second type of testing is somatic testing. You've all been hearing about all these drugs and new targeted therapy. So this is the type of testing, genetic testing, molecular testing that we do, and we do this in the tumor tissue only, and therefore the mutations that we find here are applied only to the tumor. And so the purpose of this testing is very different from the germline. Here we do this to either help in the diagnosis of the tumor, and this is mostly true for brain tumors, or to subclassify the tumor, but mostly also now for identification of potential targets for treatment. And in the same way that we have two types of testing, we use two different criteria for the interpretation of the significance of the variants. When we're looking at germline variants, we use the criteria based on the pathogenicity of the mutation. And when we are looking at somatic variants are interpreted based on the clinical impact or the actionability of the variants. And as you mentioned when you introduced me, most cancers are sporadic, and cancer is a sporadic event for the most part. And that applies to sarcomas too. There's only a small proportion of sarcoma patients that meet criteria for germline testing, and the current numbers at about 5 to 10%. But before you take that picture, take it with the X, because these numbers no longer apply. In fact, they have been, because of the significant increase in germline testing in the past years, due to many factors, including the cheaper, more accessibility and less cost of germline testing, these numbers have been challenged. And many studies have been published that have shown that the percentage of patients, cancer patients with germline mutations, is significantly higher than previously reported. And so because of that, there is a movement now that is advocating for the implementation of universal germline genetic testing for all cancer patients with solid tumors. And these people, which includes me, believe that limiting germline genetic testing only to high-risk patients is restrictive because it's not optimal care. The current guidelines are restrictive because you're preventing patients from accessing results that would help them do more effective surveillance, testing of relatives, and more effective prevention. And so, with that in mind, the conclusion from this particular two slides is that the current guidelines are obsolete and should not be applied, my belief, broadly and widely. And this is especially important in young adults because they have to make reproductive decisions, but also because, as we all know, early detection leads to early intervention, early surveillance, and then better prevention. So now I'd like to illustrate this point with a group of patients of our own sarcoma patients at NIH, and this is a small cohort of chordoma patients where we perform germline genetic testing on all of them. So it's a small cohort of 24 patients, and out of the 24 patients, all sporadic, quote unquote, none of them met criteria for testing. The family histories were all negative, and out of that 24 cohort, 9 of them had mutations, pathogenic mutations in cancer genes in the germline that we knew predisposed to cancer and are associated with well-known and delineated hereditary cancer syndrome. So, as I said before, none of them met criteria. Family histories were negative. On the outside and outside of the context of a research project, they would have not been offered testing, at least not in the United States, for the most part. And so they would have never been identified. Now that we have identified them, they're undergoing the correct surveillance program and management, and we're in the process of testing their relatives. So now I'd just like to go over and show you some of the most common. So sarcoma is rare. Hereditary cancer syndromes associated with sarcoma is rare or more rare, but we have known for many years several significant numbers of hereditary cancer syndromes that are associated with sarcoma. So just some of the most common one that you might have heard, there's familial adenomatous polyposis, and that's caused by a mutation in a gene called APC, and this is an autosomal dominant. So autosomal dominant means you only need one gene mutated to manifest the disorder. Now, all the cancer genes, no, let me rephrase that, none of the cancer genes, none of the germline cancer genes are 100% penetrant. That means that you are born with a mutation and you're born with a predisposition, and the key word here being predisposition to the disorder. But the penetrance is not 100%. There's always a percentage of patients that have the mutation and will not develop the disease. And the mutation behaves differently across generations in the same family. So we talk about, because we've been studying this for so many years, we talk about, we know now and calculated percentages. So for example, if you have the BRCA1 gene, you know that you have an 80% chance of developing breast cancer, 40% of ovarian, I'm making these numbers up because I don't do breast cancer, 16% of prostate, etc. So it's never 100. And so germline is an optional test. We ask the patients whether they want to have that information, and if they say yes or no, usually they base it on how they interpret those numbers and those percentages. It is our job to present the information to them, not to make the decisions for them. Going back to the syndromes, another syndrome, Beckwith-Wiedemann syndrome, is overgrowth syndrome where babies are born big. Many genes can cause that, also autosomal dominant and associated with embryonal rhabdomyosarcoma. Li-Fraumeni syndrome, you're more familiar with. There's a TP53 mutation. There's a founder mutation in Brazil that has a lesser presentation, or a less penetrant presentation, and that's associated with osteosarcomas and rhabdomyosarcomas and leiomyosarcomas. There's the Carney-Stratakis syndrome that was defined in an institute where the GIST patients have succinate mutations in the succinate dehydrogenase subunits A, B, C, and D, and AF2, and then, I don't know, NF1, And there's Noonan syndrome, which is short stature, also autosomal dominant, and this is associated with rhabdomyosarcomas, giant cell tumors, etc. And then the last one, I think you were mentioning, tuberous sclerosis, that's also autosomal dominant and associated with picomas and chordomas. So the way that we recognize the syndromes in the clinic when we are doing the genetic assessment is by looking at the phenotypical findings. Significant numbers of these conditions have physical findings and phenotypical findings. Because we've been seeing patients for so long, we have delineated what they look like and what their dysmorphic or different features, not dysmorphic, but different physical findings are. And so I will show you some examples. On the right left, we have a girl with Rubinstein-Tabby syndrome, and this is a syndrome that is associated with rhabdomyosarcomas and leiomyosarcomas. You can see here, she has the characteristic physical symptoms of features of the syndrome, which is a big nose, hypertaylorism, and then she has bilateral broad thumbs and toes, and that's hallmark of this disorder. Then we have the tuberous sclerosis, the famous, they call them ash leaf lesions, and those are hypopigmented areas on the skin. That's very penetrant, like almost everybody who has TBS, tuberous sclerosis has a little tiny one at least. And then we have the typical rash that's, it has, I had a senior moment, facial angiofibromas all over the face, and those are typical presentation of tuberous sclerosis. And then on the bottom, we have a girl with Thomson syndrome, also autosomal, that's an autosomal recessive, one of the premature aging syndromes. And they have a characteristic rash that's called poikiloderma that has sclerotic skin and rash, and that is very typical of that syndrome. And then you all are familiar with the neurofibromatosis and café au lait spots that present in NF1. In our own group of patients and in our genetic assessment and evaluation throughout the past 7 years with our chordoma patients, we have noted a potential new association of phenotypical findings that have to do with ectodermal and mesodermal origin, we believe. And we're in the process of assessing whether this has any genotype-phenotype correlations, not published yet. What you can see here in our patients is hypertaylorism. These are not our patients, these are just, I'm just showing the dysmorphism. So hypertaylorism, hypoplastic enamel, the pectoscabatums, multiple lentiginous, and then the hyperflexibility and the translucent skin. The interesting thing is that these are phenotypical findings that are present in a lot of the well-known delineated syndromes with connective tissue, such as Marfan, Ehlers-Danlos, but none of them have all of them together. And in our patients, the vast majority of the patients in the phenotypical group have more than 6 findings. So again, we're in the process of researching that. So now, basically, I convince you that the genetic assessment and the genetic evaluation of sarcoma patients is important, it's informative, beneficial, and it's indicated in order to implement an appropriate plan of prevention and surveillance, and that includes clinical evaluation as well as genetic testing. We still today face many challenges in order to get patients to our clinic. The first challenge that I would say is when a patient is diagnosed with cancer, the least of their problems is whether they have a germline mutation. That is a concern that usually comes later on, especially if the patients have children, but the first concern is to get to treatment. So there's also limited awareness. So a lot of patients, most patients I would say, and a lot of healthcare providers are not aware of the risk. And usually when a patient is diagnosed with cancer, we dismiss that as, oh, it's sporadic, because yeah, most of it is sporadic, but as I show you, the numbers are changing because the more we test, the more we find. And so publications will be coming once we implement universal germline testing. And I just want to clarify, I advocate universal germline testing for all cancer patients, but germline testing is always an option. So the patient has to decide whether or not they want that information. So challenges, underutilization of genetic counseling service due to lack of physician referral in the United States, but I know in other countries it's even worse. So I come from South America, and that genetic counseling is almost non-existent in cancer clinics. And genetic testing, they have to send it out, and it's such a complicated process that I don't know that any patient does it. There's also lack of standardized guidelines. So unlike the common cancers like breast and colon and prostate, we have clear guidelines. If you have this and that, you get tested, and then you get tested, and these are the percentage of. But for rare tumors, we don't have it. And so some high-risk individuals may be missed. And then last, I have been in this business for a long time, and I know that patients have difficulty communicating the results to the family members. Either they don't talk to them, or they talk to them, but they're very private and they don't want to reveal their findings. So there is a lack of cascade testing with some of our patients. And to conclude, there's more various, of course. Here in the United States, genetic testing is covered by insurance, but it's not always covered, and in order to have your insurance pay for it, you have to meet criteria. So here we are on the cycle, because if you don't meet criteria, you don't get tested, but I just showed you that lots of people who didn't meet criteria had germline mutations that were pathogenic, so that's a problem. There are some companies that, luckily, that have changed their billing, and a few, I don't know how many, that if the patient pays out of pocket, they reduce the price to affordable. But what's affordable for me may not be affordable for the guy next door, so it's still a price. And so the other concerns, some ethical concerns, I get a lot of patients that are concerned, is my health insurance going to change? And we have a protective law that's called GINA, Genetic Information Non-Discrimination Act, and it states that your insurance cannot be denied or your premium changed based on a genetic mutation, a germline mutation, but life insurance is another story. So I have lots of patients that say, let me get my life insurance in order, and then I'll get tested. And then the last one is that sarcomas are complex, is a heterogeneous group. So we have more than 100 subtypes of sarcomas, and testing them is complicated. And then with all cancer patients, in every germline test, you get variants of uncertain significance. Those are variants that, with the data today, we don't know whether they are pathogenic or benign. And so it's complicated to counsel patients with VUSs, but we do our best. Thank you.
Thank you, that was great. I know that we're going to go to lunch, but I'd like to open it up for a few questions if anyone has them. Come on up, Lenny, because I know I have some too. Oh, we'll give you a microphone.
Oh, yeah. Thank you. But I can't see. No, I'll stop.
I have a quick question.
Yeah.
So how many times do you find families where two children and teenagers are diagnosed with cancer, and then also a grandparent, and there's no, I've had all that testing that we have at MSK, and I've talked to your office because I wanted to come there. And they said, well, MSK's got it all, there's nothing. But how often does that happen? Both my children and my father. One child sarcoma, one child blood cancer, my father sarcoma.
So first of all, I'm sorry you didn't get to me, but if you, I'm happy to, well, let me just back up. So it's not common, but it can happen. And when that happens, what we do is we look at the data, we ask for the raw data, because so there's 24,000 genes in the genome. We don't know what they all do. So what we do is we look at all the data and see what genes you have or your family, you compare all the affected members and what genes they have mutated. Because what happens is when you do clinical testing, they only look at a panel of genes, and those are the clinical genes that by standard of care today have to be looked at. But there's many more cancer genes that we don't know of. And every day we're finding, not every day, but every year we're finding more. So when a family is so informative like yours, it may be beneficial to just look at the data and then compare affected versus unaffected, and then look at all the other genes that we have in the pipeline for possible key players or drivers. So having said that, I'm happy to be a resource for you.
So we have been through and our family's been very open. My stepmother offered the tissue from when my dad died. The most reasonable thing I've ever heard came from the SFA, one of the scientists there, who said there might be a connection. My dad was in country in Vietnam, was conceived while he was in country, born in Germany. But my dad also turned out to be a deadbeat, and my kids never met him, so it's not environmental. He lives in a whole other state. You know, we question cell lines, sheetrock in the house. I mean, we question everything. How did my kids get cancer? But my father too. And now I have a child getting married who wants assurance that should she have children. So, sorry, I just wonder how often that happens. But
Sure.
there was a leiomyosarcoma patient who recently passed that many of you probably knew. Her father had just, so we talked. I mean, I do think that is it really a coincidence?
No, there's no such thing as a coincidence where you find, I mean, so backing up, cancer is a common disorder, so common that it can cluster in a family by chance, but that's almost always common cancers. For sarcomas and rare tumors to cluster in a family by chance, it would be an ultra rare event. And so what we do is we get informative families where we have many affected and unaffected, and we test. But let me ask you, when you were talking about the testing was blood and saliva, not the tumors that they did in your family, correct?
They have our
Yeah, okay, yeah,
and our blood.
sure.
It's the genetics program, Dr. Walsh at MSK.
Yeah.
Your office was lovely. I thought he was on the phone with me for a long time, showing me stories about how y'all worked with other countries and found new mutations 20 years later. I'd love to be in that program for my kids' sake. My whole family would outright.
Sure, so let's talk, and I'm happy to be a resource for your family. We are currently limited on recruiting, but I'm happy to evaluate all your data, et cetera, see if I can help.
Denise, you have one last question.
Thank you very much for your talk. It was really
Thank you.
informative. I learned a lot.
Thank you.
I want to ask you about the 24 patients that you found from Cordova. That was really interesting. And then I wanted to follow up because there are no, you said that there are no guidelines on testing. What are you doing with those 24 cases? It seems like there's data there that can be expanded on, and maybe that isn't work that you all can do, but this is a
Sure,
conference about
sure,
community, right?
sure.
And working together. The Cordoma Foundation, there are
Yes.
other Cordoma groups. Is that the type of thing that you can take back to a community
Sure.
and say, okay, folks, take this further,
Yeah.
right? And then, because that bigger data helps develop guidelines.
Yeah.
Can you speak
Yeah,
a little bit about
yeah, of course. And so with the chordoma patients, so this is only chordomas, right? So it's hard to generalize that all sarcoma patients or all cancer patients are going to have germline. But the truth is that the more we test, the more we know. But first, I just want to clarify, because you said that there are no current guidelines. There are guidelines. There are guidelines for genetic testing for every tumor, but they are obsolete, or they don't apply because a negative family history is not longer should be used. But, insurance and all that. But anyways, with regard to that cohort of 24 patients, the 9 that were positive, we all obviously counseled them, put them in surveillance, talked to their doctors, and we're testing their relatives. The ones that we cannot test, because we can only at NIH test first-degree relatives, then we inform them, and I'm always a resource for testing. We also inform the Cordoma Foundation. When you go on their website, they have our paper in the page. I don't know if it's still there, but they did say, and in our last Cordoma meeting, we talked about it, and they informed. So all patients, and they were in the past sending them to us for us to test. I don't know how much that will be in the future, but yeah, and I speak and I say wherever I go that I think germline testing should be offered to every patient who wants it, because not everybody wants it. Even though most people do, not everybody, or some people are not ready to receive that information at the moment, right after diagnosis, so they come back after a year when they're doing better, et cetera. So, yeah.
Thank you. I just have a couple comments, and then we'll let you go. One is SFA has launched a full-scale survey that expands upon SPAGN's diagnosis survey, but we're asking people if they're getting genetic testing. We're asking all about testing, but genetic is one of the questions we're asking. So I'd love to follow up with you on that to understand maybe better how we could connect on that data, or maybe inform us on what we could do better. But then also, we're launching a large-scale data project to pay for patients to get tested, whole genome, like biomarker, that kind of thing. So again, I think there's an opportunity for us to have a further conversation about that because of the questions that are raised right here, because we literally just had yesterday someone reach out to us for this exact question. 2 people in the family, one just passed away, another one was just diagnosed with sarcoma and asked if there was a genetic connection. So I think this is a really good topic. I'm glad that we were able to have it here at this conference. But anyway, we need to break for lunch.
Can I just say
Yeah.
One really quick thing. So when you have 2 people with sarcoma in the same generation, or, many rare tumors passing down in a family or present in a family, it's not a coincidence. Only common cancers, 100%, nothing is 100%, but it's not a coincidence. The fact that we did not find the gene mutation today doesn't mean that it's not there. Again, 24,000 genes, we don't know what they all do. All testing is, even the most advanced testing, we don't test the whole gene sequence. We test the coding regions and the adjacent introns, only the 2 ones next to it. No clinical lab will test the whole sequence of the whole gene. And we also have promoters and RNA that we don't test in those panels. So it doesn't mean that it's not there. It means that we'll have to look deeper.
Great. Thank you so much. Thanks, everyone, and I guess we'll see you back after lunch.